So I really want to throw light on people who think we have to make a smaller axis cavity so that we are doing so much of big things to our patient and we are saving our patients. No, you're not doing any benefit to the patient by doing an extremely conservative cavities. Rather, you might miss a canal by doing an ultra conservative cavity, or else you might separate an instrument because you don't have a straight line axis. So these are the studies which have said preserving dentin in minimally invasive axis cavities does not strengthen fracture resistance of the restored mandibular molars. So guys, please don't think that you're giving strength to the tooth by making an extremely conservative cavity and not de-roofing the pulp. No, you're not doing that. What happens if you do is this will happen. Okay, if you see this case, this study is saying influence of axis cavity design on the root canal detection, instrumentation efficacy, and also fracture resistance axis in maxillary molars. So this study says the moment you're preparing an ultra conservative cavities, so you will miss the canal for sure. And sometimes if you're doing an ultra conservative cavity, your file should go like this, where there is more stress concentration on your rotary files, and you will separate the file. And by doing this, you will not benefit anything to the tooth, because anyhow the pulpal chamber is a hollow space, and you will fill it with your composites or a GIC, right? So you are not benefiting anything to the patient. Rather, patient will come back with a failure. So rather than making a failed root canal therapy, doing a big axis cavity is okay. So make sure whenever you're doing an axis cavity, make sure you're doing a good axis cavity where you can see your canals, you can clean your canals, and where you can fill your canals. That is more important than doing your ultra conservative cavities or tusk cavities or ninja axis openings. And this is one more like systematic review where they had said, like, your axis cavities does not necessarily present mechanical and biological advantages, especially when one or more surfaces of the teeth are lost. And the evidence says that ultra conservative or a truss cavity might be limited to on occasions where it is done for an intentional root canal therapies, but not for all the root canal therapies. Okay, not all the root canal therapy should be done with an ultra conservative cavity. No, the moment you remove the axis, the moment you remove the caries lesion, your tooth structure is already gone. Now, where will you get the strength? So never be in that assumption that, okay, if I do a very ultra conservative cavity, then I'm doing something great to the tooth and I'm giving back the strength to the tooth. No, the tooth has already lost its strength. You're not giving any more strength to the teeth. So yes, we all do fail, because it is all it's like not our butter and bread and butter that we have coming across since our childhood. Sometimes we do mistakes, but what is best in doing mistakes is you have to learn from it, right? So whenever we do, I see so many juniors of mine or my students say, madam, I have done perforation today, so I'm not touching the case again. So for 1 week, they won't touch the case. If they have done a separated file, they don't touch the case for 1 week. Or if they have done a perforation, no more going back and doing the case, because I had a worse nightmare and I couldn't go and do case. No, don't be like that. See, failures are okay, and getting failed is okay, but knowing how to repair is what makes you a better person from rest all. So I want you to find strength and then come out knowing what best you can do for that failed treatment, rather than not going and doing your root canals back. No, you have to come back and start doing your root canals, and also know how to repair the root canal, so that gives you more strength. So there are, as I have said, the 20% of failures that are occurring. Yes, your apical, like your crown perforations, occupies the second most failure rates in your root canals. As I've said, initially there is a 20% of failures. In that, the second most very much occurring thing is your perforations. So perforations can be a crown perforations and a root perforations. Today we'll only discuss about the crown perforations because we are discussing about the your root canals, right? Your axis openings. So this is a study which has been done in India for undergrad students, where 61 of the participating dentists has encountered a perforation, which means it's like a huge number. Out of 6 from 10 dentists have encountered a perforation. And I don't want you to be in that people who will stop doing root canals, but rather you will start repairing the root canals. So yes, MTA has in the perforation repairs, MTA has actually played a major role by using it as a perforation repair material. Initially, they used to use a POP or a GIC or amalgam. There were many materials that has been doing your perforation repairs. And after MTA, yes, actually it was an evolution in dentistry also, because MTA has been used in varied levels whenever we need to repair. So now there is a new materials and newer versions than MTA, that is your biodentin. Not just biodentin, now there are like PRF, PRP, hydroxyapatite crystals, and also your bioceramics and BC sealers. There are many materials that I've been saying that, okay, yes, you can use those materials apart from your MTA. Yes, I do support MTA, but also biodentin, because with MTA you have to wait for 72 hours, which is like, okay, I'll do a repair. I do a perforation repair now. I keep a wet cotton, seal it, and then bringing back the patient again. Now the patient cannot come so many times to you, right? And you will not know what's going on after 3 days. After 3 days, the moment you see, sometimes the MTA is there and sometimes you don't see the MTA there. So for that, to avoid all those things, your biodentin has actually made much more easier, because the working time or the setting time is less than 15 minutes for your biodentin. So you will know and you will complete the case in that first sitting, and then you can send the patient, and you will know and if you compare with the pH and everything and the properties, it is similar as your MTA and more advanced, because if you see the pH of the biodentin, it is around 12. For your MTA, initial setting pH would be around 10, and then after 24 hours it will shift. But the moment you apply your biodentin, your osteogenesis and cementogenesis, everything will start. So I prefer, yes, you can go ahead using biodentin over MTA, because they're both now available in India. They both are much cheaper prices. So don't say the patient, okay, some bad has happened, now we'll just remove the teeth because you'll have a poor prognosis. No, don't do that. Okay, start repairing your teeth, because you will have a very good results even after your perforation repairs, right? So this is one case that I have, the patient came, went to 3 other clinics. They said, okay, we'll extract the teeth. After 6 months, we'll keep an implant. This is the last molar. It's actually 7. So lower 7, the patient is not willing for the extraction. He wants to save the tooth at any point, at any cost. So the moment I saw the X-ray, I was sure. I just took my, yes, I have taken my periodontist opinion on this, because without them and my prosthodontist opinion on this, and they have said, yes, you can save and go ahead with your root canal. Okay, then I started. The moment I removed the entire thing, I could see a perforation site here. If you see, this is a perforation site, and that is where in the X-ray, this is the site, and clinically, this is the perforation site. Okay, initially I removed all the GP and all the restorative material where I could access my perforation site, and I just went in and placed my biodentin here. This is how it was placed, and kept on my calcium hydroxide dressings twice. And then I started seeing the results that were the bone formation. And then later I just filled with my entire cavity with my bioceramics. After 3 months, this is what I could see. The tooth was having a lateral perforations, apical perforation, and yes, and also crown perforations and root perforations this tooth was having. So after 3 months, I could see this change. And the tooth was more, it has come from grade 2 to no mobility also. So yes, if you do a good good repair to the teeth, yes, the teeth will come along. So if you think that, okay, anyhow it is perforated, now I cannot do, anyhow it is having a bone loss, I'll just extract. No, don't do that. Try saving the tooth and make sure you're repairing it well. Okay, that would really plays a major role in your clinical practice also. Okay, this is one more case. So to all the people who think we have to make a very conservative cavities, the moment I saw the case, this is the pre-op and this is the cavity. I have just opened. This was also said that it has to go for an extraction because you have a poor prognosis at the periapical region. And still they continue to do the treatment and then ended up in perforation. No, you don't do that. If you say the patient you are having a good prognosis, stay on it. If you're saying the patient is having a poor prognosis, stay on it. After doing the treatment and doing a perforation, you should not say that it is having a poor prognosis, let me extract. No, you have already given a hope that, okay, we'll save the teeth, then stick on it. Okay, here there was a smaller access cavity, but still I could see the perforation site, right? So the moment I just extended the cavity, I just extended the roof here. Okay, I didn't touch anything. I just extended the cavity by just removing this part of my enamel. This part I just touched and I just removed this part. If you see, now I can see all the canals. This was my distal canal. I could see all the canals. I could see my perforation site and everything. So after seeing everything, then I just took my took working length. Initially, I have shaped all the canals because I don't want to repair it at this stage. No, never. The moment you see the site, don't go repair. What happens if you go repair is your MTA will block your canals and now you'll not have access after that. Again, you'll remove entire MTA. Again, you'll perforate. No, the moment you see the site like this, go ahead and do your working length and BMP, complete your BMP. Okay, now you will have an access about where your canals are and where is your perforation site. Now what you'll do is keep a GP. Don't do obturation, just keep your GP and block these canals. I just kept my GP here and blocked the canals and then fill the entire cavity with my biodentin. Okay, ma'am, what happens if we push beyond? No, have a control. If you still have a fear that maybe I'll go into my perforation site and go beyond the site, then just take your applicator tip. I think you all know the applicator tip where you keep your bonding agent, right? It has an end, safe end. So go ahead, place your MTA and just with a gentle pressure, go inside so that you're not going beyond. You're exactly placing your MTA or a biodentin at the perforation site only, and then remove your GP, and then close it. Done. So this is how you can if the perforation is like towards the apical and you don't have a control, this is how you can go ahead and do. I know the fear is very much temporary. You might have a fear of doing maybe one day, but later if you don't do a root canals, it is a forever regret that you're not doing any more root canals. So leave your fears aside, start thinking how better you can do for the next time. That's what make you a better person. With this, I end my session.